Take as directed. Between the ages of 8 months and 4.5 years, Leah Lee was admitted to MCMC 17 times and made more than 100 outpatient visits to the emergency room and to the pediatric clinic at the Family Practice Center. Meng read the admission notes. Then, Meng well known to this facility. Meng very well known to this facility. Sometimes instead of Meng the notes say Mond or Mong or, in one note. Transcribed from a tape dictated by a resident Mongoloid, an attempt by a tired typist to make sense of a strange syllable not to be found in any medical dictionary. Under how arrived, the notes always say via Mozarms, under initial diagnostic impression, always, seizure disorder of unknown etiology, and sometimes fever, pneumonia, and infections of the middle ear, under insurance coverage, always Medi-Cal, under amount paid by patient. Always 0. Almost all the admission notes contain the phrase, language barrier. On one assessment form, a nurse's aide with a Hispanic surname has written, unable to obtain parent, speak no English. On another form, in the space marked, communication problems, another nurse has summed up the situation with a single word, Meng. Fua and Now Kao always knew exactly when a seizure was coming, because Leah knew. The aura, a sense of premonition. Common to epileptics and sufferers of migraine and angina, can take many forms, from mildly peculiar sensations, sudden tastes or smells, tingling, flushing, déjà vu, jamais vu, the feeling that an experience is utterly unfamiliar, to mortal terror. Physicians in the 18th century called the frightening auras angor animi, soul anguish, a concept any Hmong might recognize. Before Leah fell, she would run to her parents to be hugged. She also demanded plenty of hugs from them when she was feeling fine, but they recognized these occasions as different because she had a strange, scared expression, and they would gently pick her up and lay her on the mattress they kept for this purpose on the floor of their living room, which was otherwise unfurnished. Sometimes there was twitching on one side of her body, usually the right. Sometimes she had staring spells. Sometimes she seemed to hallucinate, rapidly scanning the air and reaching for invisible objects. As Leah got older, the abnormal electrical activity spread to larger and larger areas of her brain and triggered more frequent grand mal episodes. As she lay face up, her back would arch so violently that only her heels and the back of her head would touch the mattress, and then, after a minute or so of rigid muscle contractions, her arms and legs would start to thrash. During the first phase, her respiratory muscles contracted along with the rest of her body, and she would often stop breathing. Her lips and nail beds turned blue. Sometimes she gave high-pitched gasps, foamed at the mouth, vomited, urinated, or defecated. Sometimes she had several seizures in a row. Between them, she would tense, point her toes, and cry a strange deep cry. In the most serious episodes, Leah would continue seizing without regaining consciousness. This condition, called status epilepticus, when it lasts for 20 minutes or longer, is what the doctors in the MCMC emergency room feared most. Leah usually remained in a status until massive doses of anticonvulsant medication could be administered intravenously. Inserting a needle into the vein of a baby who is having convulsions is like shooting, or trying to shoot, a very small moving target. While the hapless young resident who happened to be on call maneuvered the needle, he or she was always acutely aware that as each second ticked away during the phases of respiratory arrest, Leah's brain was being deprived of oxygen. When I asked one nurse whether this caused brain damage, he said, "If you want to know what a 5-minute seizure is like, go stick your head in a bucket of water for 5 minutes and take some deep breaths." Over the course of several years, Leah was treated at least once, and sometimes many times, by each of MCMC's residents. Frightening as it was to be on duty when Leah was brought in at 3 a.m., there was probably no other group of family practice residents in the United States who by the end of their 3-year program, were so familiar with the management of pediatric grand mal seizures that the residents were merely the first line of defense. Every time Leah came to the emergency room, either Neil Ernst or Peggy Philp, the 2 supervising pediatricians who served on the faculty of the family practice residency program, was paged and, no matter how late it was, drove to the hospital, a trip that could be accomplished, at just under the speed limit, in 7 minutes. Peggy Philp was the physician Dan Murphy consulted during Leah's first admission to MCMC. The note she wrote 6 days after Leah's discharge read, in part, "This is a very interesting young infant who presents with a history of right focal seizures, one leading to a grand mal seizure. I feel that probably the grand mal seizure caused an aspiration pneumonia and hence apnea, causing her extreme distress when she showed up in the emergency room on the day of admission. The child has apparently done well on her Dilantin, although she has continued to have some right focal seizures. My feeling is that this child probably has some form of benign focal seizures of infancy. These are not especially common, but can often be quite benign in nature. Since there is apparently some chance that these will generalize, it is probably worthwhile to keep the child on Dilantin therapy to suppress a grand mal seizure. I would check the Dilantin level to make sure that it remains therapeutic. I think that the prognosis for this child's intellectual development remains good. Looking back on this optimistic document several years later, Peggy explained, most epileptics are controlled relatively easily by seizure medications. Leah's disorder turned out to be much more severe than what you usually see in classic epilepsy. Leah's chart eventually grew to 5 volumes, longer than the chart of any other child who has ever been admitted to MCMC, and weighed 13 pounds 11 ounces, considerably more than Leah weighed when she was born there. Neil and Peggy once went through a photocopy of it with me. Over a period of several evenings, the two doctors worked with the same briskness and efficiency they would have brought to a patient's diagnostic examination, arranging the thousands of pages in neat stacks, rapidly discarding any they deemed irrelevant, never skipping over, in fact, often specifically pointing out details that failed to put them in the best possible light, and stopping every once in a while to laugh ruefully at the chart's many errors. The errors were invariably made by transcribers, nurses, or other physicians. Their own contributions were flawless and usually even legible. She was seen to have lice coming out of her nose. Lice. That can't be right. Ice? Mice? Rice. Shoot, that's what it is, rice. Sometimes Neil would stop and stare at a page, often one that seemed anesthetically dull to me, and shake his head and sigh. And say, "Oh God, Leah." When we looked through the records of Leah's first visits to the emergency room, he started to flip the pages back and forth with angry little slapping motions. He had forgotten that she had had epileptic seizures for 5 months before they were diagnosed and medicated, and was wondering in retrospect whether the course of her life might have been different if his hospital had offered her optimal medical care from the beginning. Neil Ernst and Peggy Philp are married to each other. They alternate call nights, and each prayed that when a Leah Lee call came, it would be the other one's turn to roll out of bed. Neil and Peggy are both the children of physicians, both high school valedictorians, both Phi Beta Kappa graduates of Berkeley. They met when they were 19 and 18, two tall, good-looking, athletic pre-med students who recognized in each other the combination of idealism and workaholism that had simultaneously contributed to their successes and set them apart from most of their peers. By the time their lives intersected with Leah's, they shared a practice and a half, as well as an office, a beeper, and a byline on the articles they had published in medical journals. Neil's curriculum vitae, which was flush with academic and professional honors, was the only one I have ever seen that noted marital status and children first. Their schedules were arranged in such a way that one of them was always home in the afternoon when their 2 sons got out of school. Every morning, the alarm buzzed at 5:45. If it was Monday, Wednesday, or Friday, Neil got up and ran 8 miles. If it was Tuesday, Thursday, or Sunday, Peggy got up and ran 8 miles. They alternated Saturdays. Their runs were the only time either of them was entirely alone for more than a few minutes, and they never skipped or traded a morning, even if they had been up most of the night on call at MCMC. "I am a fairly driven and compulsive kind of person," Neil told me one night in the living room of their extremely neat ranch-style house, the care of which was evenly split between them. Peggy was on call at the hospital. Peggy is very similar to me. We get along real well. Real well. Medically, we complement each other. My strengths are infections, asthma, and allergies. Peggy is strong in hematology and she's better than I am in child development. When you're confronted with a difficult decision, it's nice to talk to someone whose judgment you respect. Am I thinking okay? Would you offer anything else? Can I do anything else? If I feel like a dumb shit, I can be a dumb shit with her. We don't have to impress each other. If she was not in my life, it would, well, take a while for me to be able to function. I once asked Teresa Callahan and Benny Douglas, a pair of married family physicians who trained as residents under Neil Ernst and Peggy Philp and who, like their mentors, now share a practice, what they thought of them. Teresa said, it's hard to perceive them separately. Benny said, I mean, like, Neil 'N' Peggy is the way we think of them. Neil and Peggy know everything and they never make mistakes. They are perfect. If we ever had problems, all we had to do was call Neil and Peggy and they would figure it out. Teresa said, Neil and Peggy are controlled, Neil especially, almost to a fault. I have even heard him say, about getting angry or crying, that he just doesn't feel comfortable doing things like that. But that doesn't mean he isn't compassionate. He prides himself on establishing a good rapport with his clinic patients, including some very difficult ones, some Spanish-speaking, and most patients accept what he and Peggy say as gospel and do whatever they say. Few other people I know would have gone to the lengths they did to provide good medical care to Leah. They were always thinking about her. Whenever they had to go away, they'd tell all the residents, now if this little fat Hmong girl comes in seizing. Leah was indeed fat. Her physical growth chart shows that although her height usually hovered around the 5th percentile for her age, not unusual for a Hmong child, her weight climbed as high as the 75th percentile. Her thick subcutaneous padding compounded the challenges that awaited the doctors in the emergency room. Neil Ernst wrote in a pediatric clinic note that in addition to her seizure disorder, Leah's other problem, which is of considerable concern, is the fact that she is quite overweight, which makes intravenous access during the time of seizures quite difficult. Considerable effort has gone into weight control in this child. The father apparently likes Leah the way she is and is somewhat resistant to this problem. In Laos, where food was often scarce, a plump Hmong child was perceived as healthy and especially well cared for. A vein hidden under fat is hard to palpate. Like a drug user who loses veins after repeated needle sticks, Leah eventually lost the antecubital veins in both forearms and the saphenous vein above her left ankle, after doctors frantically searching for needle placement cut them open and tied them off. During most of her hospitalizations, the arm or leg with the foreline was bandaged to a board, and sometimes she was secured to her crib as well. Leah's IVs were precious, explained Neil. The less she moved, the longer the IVs would last. One nurse's note reads, 2400, for infusing our antecubital space with signs of infiltration at 30 cchr via pump. Father here. Soft restraint to L arm. 0015, father had untied restraint placed child on cot on floor. Return child to bed, soft restraint to her arm. Tried to explain to father reason but difficult due to communication barrier. Now qaug did not understand why the nurses had tied up his daughter. His confidence in their ability to care for Leah was further strained. The morning after this note was written, when he left the hospital at 4 a.m. to catch 2 or 3 hours of sleep at home, and returned at 7:30 to find that Leah had a bump on her forehead the size of a goose egg, the result of having fallen out of her crib during his brief absence. Not only had Leah gotten hurt while under the supervision of people who claimed to know more than the Lees about how to keep her healthy, but those people had then responded to the accident in a manner that, from the Lees' point of view, was inexplicably sadistic. Phua and now qaug believed the best way to keep Leah safe and content, especially when she was ill or in pain, was to have her sleep next to them, as she always did at home, so they could immediately comfort her whenever she cried. The nurses, however, decided to guard against future falls by rigging a net over Leah's crib and caging her inside, out of reach of her parents' arms. A hospital is a scary place for any parent, Vonda Kraus, a physician at Valley Children's Hospital in Fresno who is on the faculty of the Merced Family Practice Residency Program, told me. You see people wake up your sleeping child to take their blood pressure, take their temperature, check their pulse rate, and count respirations. You see them put a bag on your kid to measure the output of urine and stool. When your child is in the hospital, suddenly somebody else is feeding them, somebody else is changing their pants, somebody else is deciding how and when they will be bathed. It takes all the autonomy of being a parent away, even for folks who have had a lot of medical experience. It would be that much harder if you were from another culture and didn't understand the purpose of all these things. Aside from the time Leah fell on her head, one or another of her parents was almost always present around the clock during her hospital stays. Some typical nurses notes, does not like to be separated from MO, relaxes when held by MO. Is quiet as long as mom holds her, otherwise screams most of the time. Child is happy babbling, plays with toys. Mom here. Babe content. Being carried papoose style by FA. Mother here breastfeeds eagerly. Cruises sides of crib. Makes baby sounds. Awake, walking around to the hallway. Would the father then return to the room? Father trying to put her back to sleep. Baby was in wagon sitting up and had generalized seizure lasting 1 minute. Father grabbed her right away, no injuries. Mother holding. No seizures this shift. Up in mom's arms, waves. Bye. The MCMC nursing staff came to know Leah well, better, in fact, than most of them would have wished. After she was old enough to walk, whenever she was well enough to get out of bed, she ran up and down the corridor in the pediatric unit, banging on doors, barging into the rooms of other sick children, yanking open the drawers in the nursing station, snatching pencils and hospital forms and prescription pads and throwing them on the floor. You'd hear that Leah was in the recalled Sharon Yates, a nurse's aide. Leah. Oh please, you'd say, don't let her up. But up she'd come. Evelyn Marcial, a nurse, said, Leah was a pretty girl, soft and cute and fast. Her mother wouldn't wean her and she was real dependent on the breast. She was a little Houdini. She could get out of anything, and she'd hurt herself even if she had her wrists bound up, so you could never let her alone. Her attention span was real short, said Gloria Rodriguez, a nurse. We taught her to say, bye, play patty cake, smile, and clap hands. But she always wanted to be held, she always put her hands up to be carried because that's what her parents did. With other Hmong families, the sons are the ones who are loved. Hmong fathers say, girl okay, if die, want many boy. But this family, they wanted so much for her to live, they just adored her. Many of the doctors remember Leah with affection because, unlike most of their pediatric patients, she was always physically demonstrative. She liked skin, recalled Chris Hartwig, one of the residents, who took care of Leah. Even when I was trying to start an intravenous line, she'd be going pick at my arm. When you asked for a hug, you could always get one from Leah. Peggy Phillips said, a lot of little kids, after being through all that, would just cry and hide in a corner or something, but Leah was very bold and she wasn't afraid of you. So you kind of liked her because she was a character, even though you hated her because she was so frustrating and she caused you so much grief. Leah hated swallowing her medications. Some nurses notes, meds given but did not like. Tries to spit out phenobarb when given. Lips pursed tightly to prevent this med given. Fought taking medicine, even crushed phenobarb tablets in applesauce. Spits well. PT very good at spitting out meds, given slowly with arms held, mouth puckered open. Spit out popsicle with medicine crushed in, had to repeat. DOS with strawberry ice cream, this time taken well. The Lees had an even harder time persuading Leah to take her medications than the nurses did, since they were reluctant to restrain her arms or force anything down her throat. And even when Leah was cooperative, Fua and now Cow were often uncertain about exactly what they were supposed to give her. Over time, her drug regimen became so complicated and underwent so many revisions that keeping track of it would have been a monumental task even for a family that could read English. For the Lees, it proved to be utterly confounding. The anticonvulsant medication originally prescribed by Peggy Philp was Dilantin, which is commonly used to control grand mal seizures. 3 weeks after her first MCMC admission, after Leah had a seizure in the hospital waiting room that appeared to be triggered by a fever, Peggy changed the prescription to phenobarbital, which controls febrile seizures better than Dilantin. Leah seized several times during the next 2 weeks, so since neither drug appeared to work adequately alone, Peggy then prescribed them both simultaneously. Consulting neurologists later prescribed 2 other anticonvulsants, Tegretol, which was originally to be used along with both Dilantin and phenobarbital, and then just with phenobarbital, and Depakine, which was to be used in place of all the previous anticonvulsants. Because lung and ear infections frequently accompanied Leah's seizures, antibiotics, antihistamines, and bronchodilating drugs were also prescribed from time to time. By the time she was 4.5, Leah's parents had been told to give her, at various times, Tylenol, ampicillin, amoxicillin, Dilantin, phenobarbital, erythromycin, Ciclor, Tegretol, Benadryl, Pediazole, Vidalin multivitamins with iron, Alupent, Depakine, and Valium. Because these medications were prescribed in varying combinations, varying amounts, and varying numbers of times a day, the prescriptions changed 23 times in less than 4 years. Some of the drugs, such as vitamins and anticonvulsants, were supposed to be given every day no matter how Leah was feeling, and when they ran out, her parents were supposed to renew the prescriptions. Some, such as antibiotics, were supposed to be given for a specific period of time, and though they were prescribed only when Leah displayed certain symptoms, the prescriptions were to be finished, but not renewed, even if those symptoms disappeared. Antifebrile medications, prescribed in the hope of warding off fever-triggered seizures before they happened, were supposed to be administered only if Leah had a temperature, a plan that might have worked better if her parents had been able to read a thermometer. Several of the medications were available in different forms, and were sometimes prescribed as elixirs, all of which were pink or red and came in round bottles, and sometimes as tablets, almost all of which were white and came in round bottles. Fua and now qaug, of course, had no idea what the labels said. Even if a relative or the hospital janitor was on hand to translate when a bottle was handed to the Lees, they had no way of writing down the instructions, since they are illiterate in Hmong as well as English, and because the prescriptions changed so frequently, they often forgot what the doctors told them. Measuring the correct doses posed additional problems. Liquids were difficult because the Lees could not read the markings on medicine droppers or measuring spoons. Pills were often no easier. At one point, when Leah was 2, she was supposed to be taking 4 different medications in tablet form twice a day, but because each of the pills contained an adult dose, her parents were supposed to cut each of the tablets into fractions, and because Leah disliked swallowing the pills, each of those fractions had to be pulverized with a spoon and mixed with food. If she then ate less than a full helping of the adulterated food, there was no way to know how much medicine she had actually consumed. At first, it did not occur to Leah's doctors that the Lees would fail to administer her medications correctly. The first few prescriptions simply read, "Take as directed." In May of 1983, 2 months after Leah's first hospital admission, when a blood test showed a subtherapeutic level of phenobarbital in Leah's system, Peggy Philp assumed that the prescribed amount was being given, and raised the dosage. The next month, when the levels tested low again, she began to suspect that when Leah's mother said she was giving the medicines as prescribed, she was either confused or lying. This was a dismaying realization. The only way to determine the optimal type and amount of anticonvulsant medications for Leah was to observe the level of her seizure activity and repeatedly test the medication level in her blood, but the test results were inconclusive unless the doctors knew exactly what was going into her system. Leah continued to have seizures, said Peggy. But was she having those seizures because she didn't have enough phenobarbital in her blood? Or was she having seizures in spite of having enough phenobarbital in her blood? And if the parents weren't giving what we told them to give, was it because they hadn't understood or because they didn't want to? We just couldn't tell. The absence of good interpreters was only part of the communication problem. Neil felt that now qaug put up a stonewall and was sometimes deliberately deceitful. Peggy felt that Fua was either very stupid or a loony bird because her answers, even on those occasions when they were accurately translated, often didn't make sense. Neither doctor could tell how much of their inability to get through was caused by what they perceived as defects of intelligence or moral character, and how much was caused by cultural barriers. Neil recalled later, it felt as If there was this layer of saran wrap or something between us, and they were on one side of it and we were on the other side of it. And we were reaching and we could kind of get into their area, but we couldn't touch them. So we couldn't really accomplish what we were trying to do, which was to take care of Leah. On June 28, 1983, MCMC asked the Merced County Health Department to send a nurse to the Lee home, accompanied by a Hmong interpreter, to try to improve the family's compliance with Leah's medication regimen. She was the first of a succession of public health nurses who were to visit the Lees over the next 4 years. One of the longest-lasting of them, Effie Bunch, told me the referrals were always the same. Febrile seizures, non-compliant mother, non-compliant mother, non-compliant mother, non-compliant mother, non-compliant mother. And the nurse's notes were always the same too. They always started out, the plan is. We all had a go at Leah and we all burned out. The visiting nurses tried putting stickers on the bottles, blue for the morning medications, red for the noon medications, yellow for the night medications. When Leah was taking elixirs, they tried drawing lines on the plastic syringes or medicine droppers to mark the correct doses. When she was taking pills, they tried posting charts on which they had drawn the appropriate pie-shaped fractions. They tried taping samples of each pill on calendars on which they had drawn suns and sunsets and moons. They tried putting the pills in plastic boxes with compartments for each day. Effie Bunch said, I remember going over there and asking the mom to show me the meds. There they would be, a little stack of bottles in the kitchen next to the tomatoes and onions, sort of like a decoration in the corner. It wasn't hard to tell that the parents were really unhappy with the medical care. Because Leah was on such high doses, she had an appointment with Dr. Philp or Dr. Ernst almost every week and had a blood level drawn 2 or 3 days before, and maybe another blood level 2 or 3 days afterwards, and there were so many changes that it was just totally mind-boggling. I don't think the mom and dad ever truly understood the connection between a seizure and what it did to the brain. And I don't know how else you get through to them that they have to give the meds. My general impression was that they really felt we were all an intrusion and that if they could just do what they thought best for their child, that child would be fine. They were courteous and they were obstinate. They told us what we wanted to hear. What we really knew about them wouldn't fill the bottom of a cup. When Leah was between the ages of 1 and 2, some of the notes the visiting nurses wrote on Merced County Health Department encounter forms were, home visit made with interpreter. Parent state infant is doing the same. We're unaware of appointment at PED's clinic for today. We're confused about proper dosage of medicine and which to give. Several meds in refrigerator that are outdated included amoxil and ampicillin. Also 1 bottle of medication with a legible label. Dr. Ernst contacted concerning correct dosage of phenobarb and dilantin. Correct administration demonstrated. Outdated medication discarded. The mother states she went to MCMC as scheduled for blood test, but without interpreter was unable to explain reason for being there and could not locate the lab. Is willing to have another appointment rescheduled. States infant has not had any seizures. Have finished antibiotic. Are no longer giving phenobarb because parents insist it. Causes diarrhea shortly after administration. Mother states she feels intimidated by MCMC complex but is willing to continue treatment there. Reluctant to give meds but has been giving phenobarb tegretol but refuses to give dilantin. State it changes child's spirit, makes face look different. Each drug is in small compartment with appropriate daytime but medications gone from wrong date at home visit again with interpreter, who explained to the mother the importance of giving all 3 medications daily at correct times. Mother has wall plaque which visually demonstrates type of med, AMT time to give medication, possible results of return of seizures if meds not given. Mother seems to understand states she'll continue to give phenobarb tegretol but only 25 mg of dilantin AM/PM instead of 25 mg at AM 50 mg PM. Agree to have continued care at PED's clinic. Home visit made with interpreter. Didn't have Medi-Cal card for child so didn't go to clinic. Doesn't know where Medi-Cal cards are. Mother has now decided to give 200 mg tegretol AM, 25 dilantin in AM and 60 mg phenobarb at night. Mother seems very agitated. Father out of house for rest of day, shopping. Mother still seems very unhappy with medical staff making decisions for daughter. Interpreter states mother is unhappy and public health nurse observed same by mother's tone of voice body. Movements. Assured mother that child can be seen in PEDS clinic Monday even without the medical card. Home visit by interpreter to discuss child's care with father. Interpreter states father also mistrusts medical system, wants another opinion but didn't state who or where. Mother states they just returned from hospital that am. Diagnosis for hospitalization unknown to mother but antibiotic prescribed. Mother says she gave client Tegretol phenobarb. This am but that she feels there is no reason to give them as they don't do anything and that the Dilantin, previously prescribed, caused the child to be wild. It did not take long for the public health nurses to answer Peggy Phillips' question about whether the Lees were being non-compliant, because they hadn't understood the instructions or because they didn't want to give the drugs. Both. Their faith in medicines had not been strengthened by two routine immunizations Leah had received against diphtheria, pertussis, and tetanus, to which, like many children, she had reacted with a fever and temporary discomfort. All of Leah's anticonvulsant drugs had far more serious and longer-lasting side effects. In some cases phenobarbital can cause hyperactivity. It may have been responsible for the riotous energy the nurses always noticed when Leah was hospitalized, and, in several recent studies, it has been associated with lowered IQ scores. Dilantin can cause hair to grow abnormally all over the body, and gum tissue to bleed and puff out over the teeth. Too much phenobarbital, Dilantin, or Tegretol can cause unsteadiness or unconsciousness. Although Fua and now Cow erroneously attributed Leah's wildness to the Dilantin instead of the phenobarbital, they were correct in perceiving that the medicines were far from innocuous. From that point, it was not an enormous leap to the conclusion they had reached by April 3, 1984, when a public health nurse noted, father had become more and more reluctant to give medications at all because he feels that the medicines are causing the seizures and also the fever. The idea that the drugs prescribed to cure, or at least attempt to treat, an illness are in fact causing it is not one that most doctors ever encounter. Doctors are used to hearing patients say that drugs make them feel bad, and indeed the unpleasant side effects of many medications are one of the main reasons that patients so often stop taking them. But most patients accept the doctor's explanation of why they got sick in the first place, and even if they resist the recommended treatment, they at least believe their doctor has prescribed it in good faith and that it is not designed to hurt them. Doctors who deal with the Hmong cannot take this attitude for granted. What's more, if they continue to press their patients to comply with a regimen that, from the Hmong vantage, is potentially harmful, they may find themselves, to their horror, running up against that stubborn strain in the Hmong character which for thousands of years has preferred death to surrender. John L. Amen, a family physician in Merced, once hospitalized a Hmong infant with severe jaundice. In order to determine whether therapy with special fluorescent lights would be sufficient or whether it would be necessary to perform a partial exchange transfusion, he had to take repeated blood samples to measure the baby's bilirubin level. After 2 or 3 samples, the parents said their baby might die if any more blood was removed. The doctor explained through an interpreter that the body is capable of manufacturing new blood, and he poured 1 cc of water into a teaspoon to demonstrate what an insignificant amount was being taken. To his amazement, his logical arguments only strengthened the parents' opposition. They said if the doctor drew any more blood against their will, they would both commit suicide. Fortunately, at this point Dr. Aleman asked his Hmong interpreter what he should do, a strategy not open to Leah's doctors during her early years, since no competent interpreter was available. The interpreter volunteered to call a Western-educated Hmong leader who was likely to understand the doctor's treatment plan. The leader called the head of the family's clan, the head of the clan called the father's father called the father talked to the mother, and, having thus received the request through a familiar and acceptable hierarchy, the parents were able to back down without loss of face. The baby had the blood tests and was successfully treated with phototherapy. In 1987, Arnie Vang, a 2-year-old Hmong boy who lived in Fresno, was diagnosed at Valley Children's Hospital with testicular cancer. Arnie's real name, the one conferred in his Huplig ceremony, was Tong, but his father preferred to call him Arnie because it sounded more American. His parents, both teenagers who had attended American high schools and spoke and read English fairly well, consented, though reluctantly, to the surgical removal of the affected testis. After the surgery, Arnie's doctor, an Indian-born oncologist who had never had a lung patient before, explained that the next step was a course of chemotherapy. She handed the parents a piece of paper on which she had typed the names of the drugs he would receive and their possible side effects. Her predictions turned out to be accurate. Arnie, who had appeared perfectly healthy after his surgery, lost all his shiny black hair within 3 weeks after his first cycle of chemotherapy, and every time the drugs were administered, he vomited. Arnie's parents concluded that the chemotherapy was making him sick and refused to bring him in for further treatment. After giving the Vangs 3 days warning, his doctor called Child Protective Services, the state agency that deals with child abuse, which dispatched 2 social workers and 2 police officers to their house. And Arnie's mother, Dia Xiong, explained to me later, "When they come, my husband isn't there. I say, wait for my husband. But they say they can't wait. I say, please that you go away. I hold my son. I hold him so tight. I say, give my son back. 2 police, they hold my hand behind my back. I can't move. I am scared. My 2 daughters are crying. The police hold my hand, they take my son away. I scream and cry. Then I take my husband's guns from the bedroom closet. They were 2 long guns. We bought them to shoot squirrels and deer, not to shoot people. I say I will kill myself and the little girls if they don't bring him back. I just yell, please bring my son back to me. I say, just bring. I want to hold my son." A SWAT team was summoned, and for 3 hours the Vang's immediate neighborhood was closed to traffic. Finally some police officers brought Arnie back from the hospital, and when Dia Xiong saw him, she dropped the guns and was driven, in handcuffs, to the psychiatric unit of a local hospital. She was released the next day, and no criminal charges were filed against her. Arnie's doctor administered one of the 3 remaining cycles of chemotherapy but agreed, although it was against standard protocol, to forego the last 2. Arnie is still in remission today. His doctor was haunted for years by the thought that 3 lives were nearly lost in order to save one, and for that one life, she told me, her voice shaking and her eyes filling with tears, the cure wasn't even 100% certain. One night, while Liao Li was in the emergency room at MCMC for the umpteenth time and a translator was present, Dan Murphy, who happened to be on call, brought up the subject of her anticonvulsant medications. Her mother informed him that she didn't think you should ever have to give a medicine forever. It is likely that the only Western drugs Phe and now Qaug had encountered in Asia were fast-acting antibiotics. Dan recalled, I remember that I was just watching them and they looked very resolute, like, we are doing what we think is right. They weren't about to take any garbage. I felt they really cared for Leah, and they were doing the best, the absolute best they knew how as parents. To take care of the kid. That is what I felt about them. I don't remember having a feeling of anger, but I remember having a little bit of a feeling of awe at how differently we looked at the world. It was very foreign to me that they had the ability to stand firm in the face of expert opinion. Neil and Peggy are easily the best pediatricians in the county, yet Leah's parents didn't hesitate to say no to them or modify the drug dosage or do things however they saw fit. And the other thing that was different between them and me was that they seemed to accept things that to me were major catastrophes as part of the normal flow of life. For them, the crisis was the treatment, not the epilepsy. I felt a tremendous responsibility to stop the seizures and to make sure another one never happened again, and they felt more like these things happen, not everything is in our control, and not everything is in your control. Soon after this encounter, in the late afternoon of January 20th, 1984, Dan Murphy was on call again when Liao came to the emergency room in the throes of a grand mal seizure. Among the notes he dictated were, the patient is an 18-month-old Hmong child with a long history of seizures. The parents report that they had discontinued the medications about 3 months ago because the patient was doing so well. Dan did not have much time to reflect on this alarming news, because shortly after he started Leah's phenobarbital 4 and admitted her to the hospital, he was called to assist at another emergency room crisis in which the patient died, and, immediately thereafter, he was summoned to the obstetrical unit to deliver a baby. At 11:20 p.m., in the 13th hour of a 33-hour shift, Dan was paged because Leah had started seizing again, this time violently. Since Leah had responded well to the phenobarbital, Dan had not summoned Neil Ernst or Peggy Philp to the hospital. He therefore had to deal on his own with the most severe episode of status epilepticus Leah had yet suffered. He administered 2 more massive doses of phenobarbital. "Sometimes you have to give so much medicine to stop the seizure that they stop breathing," said Dan. That happened. Leah turned blue. First, Dan gave her mouth-to-mouth resuscitation. And when she failed to resume breathing on her own, he decided that a breathing tube had to be placed down her trachea. Leah was only the second child I had ever intubated under crash circumstances, and I didn't feel all that confident. You have this instrument that looks sort of like a flashlight, with a blade that snaps down, and you have to get the tongue out of the way. And the problem is that if you don't know exactly what you are doing, instead of putting the tube down the trachea, you put it down the esophagus, and you start to ventilate, but the patient is not getting any oxygen. So it's literally a do-or-die situation. Either you get it in and they do okay, or you don't and they might die. This time I saw what I needed to see, and the tube went right in and it worked perfectly, and I felt really good. I thought, well, I guess I am becoming a doctor. Leah's parents were standing outside the ward while Dan intubated Leah. By the time they came back in, she was unconscious and she had this tube taped to her mouth. I remember that they were very upset about that. I remember that the mother just had a very displeased look on her face. Because MCMC was not equipped with a respirator for babies, Dan decided that Leah, who was being given oxygen on a temporary basis through a manually operated bag, should be transferred by ambulance to their pediatric backup facility, Valley Children's Hospital in Fresno, 65 miles south of Merced. She regained consciousness there, and was able to breathe on her own after 24 hours on a respirator. Leah spent 9 days in Fresno, spiking high temperatures from aspiration pneumonia and gastroenteritis, but did not seize again. On her history and physical examination form, her name is listed as Lai Lee. On her discharge summary, she is Lee Lei. Through an English-speaking cousin who accompanied Phu and Now Cao to Fresno, the admitting resident was told that Leah had been off medications for 1 week, rather than the 3 months recorded by Dan Murphy, because the prescription had run out and the family had not refilled it. The resident wrote, without irony, "I am not entirely sure if all the history is reliable." 2 months later, Peggy Philp noted in an ambulatory care physician's report that Leah, who was then 20 months old, had no words, although used to say sev words. In her diagnosis, she wrote, "Dev a delay," a conclusion she had dreaded reaching for some time. It is not surprising that a child who had seized as frequently and severely as Leah was beginning to show the first signs of retardation, but Neil and Peggy found the situation particularly tragic because they considered it preventable. Looking into Leah's future, they foresaw a steady decrease in intellectual capacity unless the Lees started giving Leah her anticonvulsants regularly, and even that might not halt the decline, since the brain damage resulting from her erratic medication regimen had already made her seizure disorder far less tractable than it would have been if compliance had been perfect from the start. Neil and Peggy perceived Leah as being more retarded, though still only mildly so, than the visiting public health nurses did. Effie Bunch said, "The doctors only saw her when she was sick and never in her home environment. When we saw her, sometimes she was a wind-up toy because of the phenobarbital, and sometimes she was post-seizure and looked like a little ball of dough in the corner, but sometimes she was just bright and cute and actively playing, happy, gay, climbing, crawling, on her mother's back, laughing and chattering and what have you." Testing Leah's intelligence was difficult because her hyperactivity made it hard for her to focus on assigned tasks, and both the doctor's instructions and Leah's verbal responses were always filtered through interpreters of dubious competence. When Neil and Peggy administered a Denver developmental screening test at 14 months, the results were normal. But at 22 months, although Leah passed, plays ball with examiner, plays pat a cake, imitates speech sounds, and neat pincer grasp of raisin, she failed a uses spoon, spilling little, washes and dries hands, points to one named body part, 3 words other than mama, dada, and a tower of 8 cubes. When Leah was 2, a consulting neurologist recommended that she be started on Tegretol, continued on Dilantin, and gradually weaned off phenobarbital because it was contributing to, or even entirely causing, her hyperactivity. Unfortunately, the Lees had now decided that they liked phenobarbital, disliked Dilantin, and were ambivalent about Tegretol. A visiting nurse once found Leah dazed and staggering after receiving an overdose of phenobarbital, which, though it can raise some patients' energy levels when taken in normal doses, has the opposite effect when taken to excess. The next day, when Leah was brought to the pediatric clinic, the resident on duty, who happened to be Gary Thusen, the doctor who had delivered her, noted, apparently parents felt if phenobarb was good 2x is better so double-dosed yesterday. On July 20, 1984, Neil Ernst wrote in a pediatric clinic note, a copy of which he sent to the health department. The mother states that she will not give the Dilantin at home. In addition, she also states that she has increased the child's phenobarbital to 60 mg, BID. Finally, the mother states that she ran out of Tegretol, and the child has received no Tegretol in the last 4 days. The mother brought a large sack full of medication bottles, and on closer examination by myself there were 3 half-empty bottles of Tegretol. The mother stated that she was unaware that these bottles were Tegretol. In addition, the mother also was unable to identify the Dilantin bottle and gave that bottle to me and said that she did not want it at home. On rereading this note many years later, Neil said he could still remember the rage he had felt when he wrote it. He and Peggy, who are both aware, and even proud, of their joint reputation for glacial unflappability, couldn't remember another case that had made them feel this way. I remember wanting to shake the parents so that they would understand, said Peggy. A handful of times, Neil gave Fa a hug while Leah was seizing, but most of the time, while Leah was between the ages of 18 months and 3.5 years, he was too angry to feel much sympathy toward either of her parents. The best thing I could have given Leah's mother was compassion, and I wasn't giving her any, and I knew that I wasn't giving her any, he said. There was just too much aggravation. It was like banging your head against a wall constantly and not making any headway. There was the frustration of the nighttime calls and the length of time it took and the amount of energy and sorrow and lack of control. I mean, every time I saw Leah I would just, it was like, oh. You would just get so frustrated. When she came to the emergency room in status, there would be sort of like a very precipitous peak of anger, but it was quickly followed by the fear of having to take care of a horribly sick child who it was very difficult to put in for in. Peggy added, some of the anger came from that. From our own fear. It was hard to work so hard and not receive a single word of thanks, in fact, to have their efforts invariably greeted with resentment. Neil and Peggy never dwelled on the financial aspects of the case, since one of the reasons they chose to work in Merced was, in Neil's words, to serve underserved people regardless of their form of payment. But it was an undeniable fact that Leah's family had never paid a penny for the hundreds of hours of care she had received, and yet failed utterly to appreciate the generosity of Medi-Cal and of Neil and Peggy's services, which, because of the low level of reimbursements, were, in effect, partially voluntary. No other pediatricians practicing in Merced at that time were willing to accept Medi-Cal patients. The Lees also never showed their doctors the kind of deference reflexively displayed by even their most uncooperative American patients. It was as if Neil and Peggy's 4 years of medical school, their 3 years of residency, their awards, their publications, their telephone consultations with neurologists, even the hours they spent in the Merced Public Library reading old National Geographic articles about the Hmong, all counted for nothing. The worst aspect of the case was that as conscientious physicians and dedicated parents, they found it agonizing to watch Leah, as it would have been for them to watch any child, fail to receive the treatment they believed might help her lead a normal life. And it seemed as if the situation would never end. However frustrated they were, they never considered abandoning the case. Unless Leah died, they could see themselves driving to the emergency room in the middle of the night until she was grown up, and had graduated to the care of an internist, with whom they already felt an anticipatory bond of sympathy. In June of 1984, Neil and Peggy found out that Fua was pregnant again. They were appalled. This baby would be number 15, 8 had survived. Fua's age was unknown, it was listed on her maternity registration form as 58, a number no one at MCMC seems to have questioned, but Neil and Peggy had assumed that she had already gone through menopause. When we found out she was having another, we said, "How could this happen?" Neil recalled. "This must have been the last egg that was possibly fertilizable, and it got fertilized. We were just dreading how this baby might turn out, that it might have Down syndrome and heart problems, and that we were going to have to deal with 2 sick kids in this family. Just what we needed." Leah's mom refused to have an amnio. Not that she would have aborted anyway. Fua also vehemently refused a tubal ligation, a sterilizing procedure. Urged by a nurse who knew Leah and feared another Lee child might be born with epilepsy, she continued to breastfeed Leah throughout her pregnancy. On November 17, 1984, when Leah was 2.5, Pang Lee, a healthy, vigorous, completely normal baby girl, was born. After the birth, Fua breastfed both Leah and Pang. She was exhausted and, according to a child welfare report, overwhelmed. On April 30, 1985, 4 days after Leah's 11th hospitalization, at MCMC, a visiting public health nurse found that the Lees were giving Leah a double dose of Tegretol pills, which they had stored in an old phenobarbital bottle. On May 1, the nurse noted that Leah's father now refuses to give any Tegretol whatsoever. That same day, Neil noted that when Leah came to the pediatric clinic, the family stated to me through the interpreter that they have stopped the phenobarbital 5 days ago, and the child apparently has received no phenobarbital since hospital discharge. Mother stated that the combination of Tegretol and phenobarbital was too strong for the child and she decided to stop the medication. Neil sent a copy of this note to the health department and to Child Protective Services. In it, he also wrote that because of poor parental compliance regarding the medication, this case obviously would come under the realm of child abuse, specifically child neglect. Unless there could be some form of compliance with the medication regimen and control of the child's seizure disorder, this child is at risk for status epilepticus, which could result in irreversible brain damage and also possibly death. It is my opinion that this child should be placed in foster home placement so that compliance with medication could be assured. The Superior Court of the State of California immediately acted on Neil's request, declaring Leah Lee to be a dependent child of the juvenile court who was to be removed from the custody of her parents.